Can you see it now?
Yes, sir. Yes.
Yeah, come down. Slightly increase it. Yeah. 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 So now we'll inject the drug. So 20 ml of 10 ml of lignocaine adrenaline, and I'm going to give 10 ml of 0.5% bupivacaine. So I just wanted, aspirate. Yeah, inject. You see there is no bulge that's happening. That means it's going along the perineural tissues. So 10 ml of So 20 ml of the drug is in situ. To repeat the plot, identify the pubic tubercle anterior superior iliac spine, and just below that inguinal crease, with the tip of my thumb I palpated the femoral artery. I went to the lateralmost margin of the femoral artery. From there I went 1 centimeter lateral and 1 centimeter below. Can you see that where I pierced the needle? When I pierced the needle first, I got the sartorius contractions. When I got the sartorius contraction, I made the needle go a little bit posterolateral, and I looked for the quadriceps contraction and decreased it from 2 milliamps to 0.5 milliamps and injected 20 ml of the drug. It did not produce any bulge, clearly showing that we are inside, and I am just removing the needle. You see the depth was 1.5 centimeters. So I got the femoral nerve within 1.5 centimeters, and the end point we saw was a quadriceps contraction. Normally I use a 50 millimeters needle for this, but since we decided to go for also a sciatic approach, we used 10 millimeters. So ideally 50 millimeters it would have been easy, but the initial little struggle was to come back again and do it, and that particular point of time, because the first injection if I had done, I wouldn't have sedated, but because the patient started having the discomfort, I didn't want to do a procedure with discomfort, so we just gave 1 milligram midazolam and 3 cc sleeping dose of propofol just to make her comfortable, and I went ahead with the block again, and you saw the quadriceps contraction. So this is the femoral block. Take home message: below the inguinal crease, palpate the femoral artery, I palpate with my thumb, and palpate the artery is very big, palpate in its entirety, and the tip of the thumb should be in the lateralmost part of the artery. Push the artery medially, from there go 1 centimeter lateral and come down 1 centimeter below and go perpendicularly like this. So go perpendicularly like this. It's a superficial nerve. You will get within 1 to 1.5 centimeters. In obese individuals, 2 to 2.5 centimeters, not more than that. And initially when you had a sartorius contraction, which is supplied by the anterior division of the femoral. And if you get only sartorius, then majority of the time the posterior part of the nerve is posterolateral. So I tilted the needle, the tip going posterolateral, and then I had the quadriceps contraction. So then we decreased the current from 2 milliamps to 0.5 milliamp, and then we injected the drug. So is that very clear?
Yes, sir, it is very well explained. In surprise too.
And so the femoral block can be used for all hip fractures, can be used to take skin grafting from the thigh, and can also be made sure that any kind of procedure that they wanted to do here, especially some of them do
So
the.
patient is not visible.
Now I was speaking, so
Okay.
yeah, the node biopsies, grafts, all these things can be done here. And now we will go on to show the Raj technique, where it's a easy sciatic block which I wanted to show you. A block which can be done in the supine position. For example, you get a patient with diabetic foot. I think this is a block which every private practitioners can do. And because this is based upon two bony landmarks. On one side it is the, I will show you. So on one side is the greater trochanter, and the other side is the ischial tuberosity. I will demonstrate that. And the way I am going to do the block is I am going to sit on the side. Can I have a stool? Can I have a stool, please? Stool. And I need an assistant to just lift this. I need one. Ek minute. So what I'm going to do is I'm going to show the position in which I'm going to sit, and I'm showing a sciatic also. I need someone to hold the leg, and I would also need betadine. So patient in supine position, and maybe you can give 2 more cc propofol. Just 2 cc. Okay, so now I would want you to lift that, yeah. So now, yeah, lift it and then flexion here. So flexion at the hip and flexion at the elbow. And you have to come. Is there a perfect? So now can you just see the hip is flexed and the knee is flexed? Submitted. You can have some saline. Saline. Gauze piece. Now connect to the machine. Nitu, is the position seen well? Right. So now we are all set. So now it is flexed. Yeah, that's perfect. Yeah. So now I'm palpating the. So on the medial side, the thumb is palpating the ischial tuberosity. It's like a flat bone, and this side is the trochanter. I'm feeling the greater trochanter laterally, and I'm ischial tuberosity. So now I am visually drawing a line between the two. Okay, the greater trochanter and ischial tuberosity. Are you able to appreciate this?
Yes, sir.
My tooth One, this is on ischial tuberosity medially, and laterally it's on the greater trochanter. And now I am going to take the midpoint of this in a line that is joining between the two. This is the insertion of the needle, okay? So now, unlike brachial block and unlike femoral block, the sciatic nerve can have certain anatomical variation in its relationship to the bony landmarks. So may not be as easy as the femoral, but not too difficult as well. So point number one, ischial tuberosity. Point number two, the greater trochanter, the line joining the two. And I'm going to insert at the midpoint of that line joining the two, perpendicular to the line and parallel to the ground. Can you see the needle?
Yes, sir, we can see this.
Yeah, can you appreciate where I have put it? We will give 2 cc of propofol to make her comfortable because it's a deep block and I don't want to make her very uncomfortable. At the same time, I don't want to give her general anesthesia for her. Just mild sedation because it's a deeper block and make her comfortable. Yeah, make her comfortable, and then now I have to look for contractions here, plantar flexion or dorsiflexion. Is she comfortable? Yeah. So I'm pushing my needle. This is a 100 millimeters needle. Can you see that?
Yes, sir.
Okay, so now we are decreasing it from 1.7, 1.6, 1.6.
सर कॉन्ट्रैक्शंस अभी बहुत क्लियरली दिख रहा है so थोड़ा सा और
0.5.
थोड़ा कम हो गया हाँ अब better.
Can you see that?
Yes, sir.
So injecting the drug. So Neetu, don't you think this is easy?
It's very easy when you are doing this. It will be very difficult for me, maybe.
So it's one of the easiest way to block the sciatic. And look at, palpate the ischial tuberosity, palpate the greater trochanter, draw a line between the two, go to the midpoint of that, and go perpendicular to that line and parallel to the ground. Look for the dorsiflexion, plantar flexion, inversion and eversion, and decrease the current from 2 milliamps to 0.5 milliamps and inject the drug. So, 4 milligram. So this is actually a life-saving block. Patients who come with diabetic ketoacidosis and diabetic foot, even in private practice, and if they're on antiplatelet drugs like clopidogrel, and where you can't give a drugaxial block and they are diabetic ketoacidosis in sepsis, low blood pressure, surgeon wants to do a debridement, and this is the block that you need to do. This is the block which will produce in a diabetic foot an excellent quality of surgical anesthesia below the knee joint, and I'll show you how to block the saphenous also. So now it's done. I'm removing the needle. So can you focus this? So 1, 2, 3, 4. We have got at a depth of 4 centimeters. Okay? Right. And now, so we have done with the sciatic. Yes. Thank you so much. And she held it very well. So that's why the success of the block is because of her and not because of me. And one thing I wanted to show is, after you do this for a diabetic foot, the saphenous nerve becomes a cutaneous nerve and supplies this part of the leg. So this is the tibial tubercle. So what I wanted you to do is infiltrate subcutaneously about 4 to 5 ml of the drug from the tibial tubercle.
Can we focus?
Yeah,
Focus.
Focus. No, I don't want to give it. I just want to explain to them because we have already given. See, suppose I already given a femoral block. In this patient, saphenous will be covered. But if you want to do a diabetic foot, femoral is not needed. You do the sciatic block like what I showed. And the only thing below the knee joint which has to be covered is the saphenous, which is a branch of the femoral. So you identify the tibial tubercle. Can you see the tibial tubercle, Neetu?
Yes, sir.
So from the tibial tubercle along the medial shin, you infiltrate subcutaneously 4 to 5 ml. The staphylos is blocked, sciatic is blocked. You can do it. Yeah, yeah.
Morning, sir.
Good morning.
Can we do this any combination of this block or total knee replacements?
Yes, ideally, answer is yes. For example, we have done a patient who had a significant scoliosis and who didn't